what has been done with intent of face this dramatic surge. There was as I alluded to in my previous slide, the creation and conversion of structure into COVID hospital, fair hospital, the ICU capacity outside the ICU. And I leave you imagine how difficult it may be, because if the personnel who is specialized in critical care medicine is focused into the ICU and assisting these patients, but you need to allocate these patients also outside the ICU, those specialists, those doctors, they have the responsibility to take care of them, are not specialists in critical care. So we were obliged to train them very shortly for the essence, and they had to assist them. I leave you imagine how difficult it may be. And on top of that, there were also the problems of mechanical ventilator. You know that a patient who is in a respiratory insufficiency into the ICU, for being helped to breathe, needs a mechanical ventilator that, in a way or another, replace the respiratory function of the lungs that are affected by the disease. And if you don't have a ventilator, the story becomes quite difficult. And the other problem that we didn't have enough time to give an adequate training. So I want to show you how we did. In my hospital, we were relatively lucky because we had a building, a sanitary building, dedicated to the conventional activities. And in 1 week, so I leave you imagine how hard was the work of the technicians, they transformed the normal and conventional ICU area, the wards, into ICU, just bringing the oxygen supply, the air supply, and equipping all the different places in the proper bed. But at the national level, this effort that translated into a fast increase of the availability moved for a total of 5,300 beds up to, that corresponded to 1 ICU beds per 1,000 inhabitants to up 1.4, which means moving up to the number of something like 8,000 beds. And we were the first. And being the first, we had also the privilege of being quoted by the CNN when the first patient entered our new hospital that we transformed. But to face this difficult situation obliged us also to find out new strategies. And for instance, one thing that has been done everywhere was separating the way of admission to the hospital between those patients who didn't have the COVID-19 and those who did. It means creating the isolated areas into the hospital that didn't exist before, just building up a wall and reconverting the area in a very, very short period of time. And changing the strategy at time push our creativity. I can tell you that during those days, by using simply WhatsApp, all the ICUs of my region were interconnected, and any moment we know what was the situation of the patient admitted to the ICU, the various ICU, and where the ICU beds were free. Just completing, cutting off the normal network and distribution through the centralization and coordination, simply because we need to solve the problems very rapidly. WhatsApp. So something that was never attempted before. But the other problem that we didn't have enough resources. We didn't have enough masks. We didn't have enough ventilators. We didn't have enough gloves, everything. And in this document is coming out, that came out from the ECDC, which is the Infectious Disease Control Agency at European level. There were suggestions how re-sterilized masks and other devices utilized for the assistance to the patient because the lack of resources. And this is something that was coordinated at our national level by the Superior Institute of Healthcare and the Ministry of Health, just in order to find out a coordination at the national level and international level. And this translated into our committee, scientific committee, in a constant daily analysis of the resources that were proposed. And I can tell you it was really difficult, because at times I had the obligation, because of my specific competence, of evaluating the possibility of getting certain ventilators from here and there in the world. And at times, making this evaluation only looking at the technical report and the brochure is obviously not enough, and was indeed a lot of stress, because you never know if what is written really corresponds to the efficiency of the machines. But this was something really important also at the European level. The European level created a commission for the device procurement, where a commission, and I was included in this list of colleagues coming from all over Europe, that had the task of evaluating the different machines and the different devices that were given or offered to Europe, with an additional problem. Think that at that moment, all over the world, there was a crisis, and the countries were in competition each other for keeping the resources and without delivering outside of the country. And so we entered in competition for the number of mechanical ventilators that we had to use, with Germany, with the UK, with France, and this was even more terrible. And this was one of the reasons why the European Commission, the EU, created this specific committee in order to be balanced, avoid any excess from the various countries, and distributing the resources. And the problem of human resources, think about that. An intensivist, to be perfectly trained and qualified, needs something like 5 or 6 years. We cannot create from nothing. It takes time. And so the only thing that we could do in any country was just to recruit the residents, the specializing doctors that indeed worked beautifully, with a dedication, with a strength really remarkable. And I can tell you that the other thing that we should do, train for the essential the people that was already into the hospital. And for these reasons, for instance, European Community and the European Society of Intensive Care Medicine created a brief trained and a program that helped to, in a way or another, give the essential, as I mentioned before, to those who were not critical care doctors, in order to utilize these new forces and resources for the essential and treating these patients, also the outside the ICU. And there was an immense effort coming from the international society for creating guidelines in very short period of time that suggested the clinician how to do and how to behave, how to treat these patients, having good infographic and showing which could have been the best solution for that patient given certain symptoms and pictures. And the distribution over time of this period of training had a regular interval in order to recruit as much as we could in terms of human resources. But during this time, because we were also asked to produce science, giving something reference that could be utilized by the doctors. We were contacted at that time from the colleagues coming from all over the world. I received a lot of calls from the US, a number of friends that were trying to know what was our behavior, how we could find the solution. And just in order to see, this is one of the first publications into one of the most prestigious medical journals, the JAMA, and where the number of patients who were mechanically ventilated were the vast majority, once again depicting and underlining how difficult it was, because all those patients needed the support, needed the oxygen and all the rest. But at the same time, just going deep into the knowledges that increased our capabilities for understanding the disease, we could delineate also a specific subtype, a phenotype, that could just identify those category of patients who were more severe in terms of impairment of the pulmonary vasculature and the parenchyma, the tissue of the lung. We also proposed other alternative technical support, and for the first we launched the helmet, adopted into the various contexts, and in the very end we could solve the problem. Conclusions. For sure, COVID-19 was the worst health crisis of our times, after maybe the flu, the Spanish flu. In general, those who were more touched and hit by the pandemic was the older. Maybe especially for the youngers that I guess that the younger person that are seated into the room had a tangent touch of the pandemic. You probably were closed into your houses, so you couldn't go out. Maybe, this is my extrapolation. And this is something that obviously psychologically was very important for you and was very hard. We look at the pandemic for exactly the other waterfront. We are deeply involved, but we as doctors, I can tell you, have exactly the same scars that you have in your soul.
We thank you very much. This is a tragedy that I don't know when and if we will be able to overcome. I think that each of us has a special remembrance of particular cases, and I know because in my family are all doctors, so I know directly that they really were living a kind of internal continuous asking what is the best thing. I have 3 people, I can take care of 2, and the third one, what we can do with the third one. And it was had to decide in a few minutes because the time was another variable, very important and seriously affecting the result. So I think that this experience, there are students of medicine also here. Ah, good. Because we organized working groups mixed. Mainly in ICT, but also... Oh, no, another one is for medicine. I don't see her.
No medicine.
Okay, we will propose them a team that they will develop. So a challenge, a scenario, critical scenario, and they have to take decisions. So we will see what they will be able to do.
You see, in these cases, maybe something that have rendered not easier the things, but certainly proposed some solutions, was the triage. I do not know if you know what the triage is. Of course, there are people coming from the civil protection who are very well keen in this aspect. But triage is the selection of patients. Yes. If you are in a battlefield, for instance, you have wounded people, and you have to evacuate those who are wounded, you have to choose, if your resources are limited, those who can survive. Yes. And at times, those who are more serious should be left in the battlefield. Yes. This is very hard, but if you want to at least save someone, this is what you have to do.
Thank you. Thank you. Nice to meet you.
Nobody volunteers, come on. Only crisis, we need volunteers, people.
Very young people are volunteers. Okay. First pair of blues, please.
Okay. I know that my team is going to be probably sending every photograph back to Middle City.
I guess I'm with you like that.
You'll be doing the washing today.
Sorry. The measure, also the measure was a problem.
But you have to realize it takes time to put them up. It feels like Stansted Airport, doesn't it?
Yes.
Oh my God, what did I sign up for?
Stop.
Stop, huh? That's honestly for a far taller person. I forgot I need to use the toilet.
Oh, good suggestion.
Go ahead.
It fits you very
Thank you. I like the color. Full. Oh yeah. Okay.
Yes, my 30 minutes have to.
I can paint your house. It's very hot now.
Really? No, don't say this. Are you hot? Really? No.
Second.
Don't forget the gas.
You know what's going to... Are you all going to clap for me at the end of the session? Right? Yeah.
For the second pair, you should put this.
You know, in England, we had everybody clapping every Thursday. Is that enough? Yeah.
What's her name, please?
Huh? George.
Can you stand here?
Yeah, I can do it.
Just stand with us. Yeah.
Did you tell him
See what-
he had to stay that way for 2 hours?
Yes, I asked them only for my presentation.
It's okay, I just need to lose weight, so I'll do that.
But this is not a joke. Anyway. In 2005, the WHO required to all the member states to establish, operate, and maintain a national public health emergency response plan, including the creation of multidisciplinary, multisectoral teams to respond to events that may constitute a public health emergency of international concern,
In addition, countries need to prepare for any events that would constitute local or national health emergency. The response to health emergency includes a set of measures, strategic, operational, and tactical, to reduce morbidity and mortality and maintain or restore essential health services. I want just to underline that for us doctors, strategy, operations, tactics are not our language, but it became. This process improves country-level preparedness and response capabilities through the engagement activities to increase understanding of emergency systems, development of an emergency operation plan for health, or an emergency preparedness and response plan, and a response planning roadmap to identify key areas for improvement and links into preparedness and capacity building initiatives. These initiatives could include a national action plan for preparedness and response, also known as national action plans of health security. So also already in 2005, we were talking about national health plan. There is another underline. The toolkit covers sudden onset and slow onset events. The sudden onset events include infectious disease outbreaks, earthquakes, tsunamis, and chemical spills. But there are also the slow onset events, which include deteriorating situations where the public health risk may increase over time, such as progressive disease outbreak, droughts, or food insecurity, or maybe also wars. In the five, maybe they weren't thinking about war, not in that period. Emergency may also be complex in nature, combining more than one type of hazard, such as armed conflict, in which an emergency response has to be conducted in a difficult political and security environment, potentially involving a multi-sectorial international response that goes beyond the mandate of capacity of any single agency. This morning we heard about this. Are you okay? Are you hot? Can you breathe?
I can breathe. Barely.
Okay. I'm a doctor, you know.
It's okay. I'm not going to collapse, I told you.
For this reason, although the toolkit was developed for public health authorities, it highlights the requirement of interoperability between the health sector and other sectors' emergency plans. Also, you can think about the earthquake, the L'Aquila earthquake, the sanitarian risk, the health risk, or the health management was going together with all the other approaches. The EOP, also known as emergency response plans, ensure the provision of rapid and coordinated action during or immediately after an emergency to save lives, reduce the health impact, ensure public safety, and meet people's basic health needs. So now we are in a world in the prevention management. What does it mean? It means that in peacetime, and healthcare needs to pick up proper territorial analysis and networking with those involved in the safety of the territory and people. In peacetime, where there isn't the earthquake, where there isn't the pandemic, where we are quite quiet, it means carrying out the necessary interaction between political structures, municipalities, provinces, regions, especially if they are adjacent to each other in order to know the response capabilities that can be quickly prepared. If I think of my small village, I live in a 3,000 people village, I had to know if the village beside mine has maybe the tractors to take away ruins, for example. We can join together, but we have to decide this before the events. Establish protocols of understanding with similar structures by type of intervention, including between public and private entities, for example, especially in the sanitarian pathway, and stakeholders too. Supply the warehouses with the surplus quantities of readily available materials, because we have to have this before the emergency. What happens instead in the emergency management? We have at the local events, through close interaction with civil defense, public administration, volunteers, and stakeholders, try to work together to give our best in that moment. And through interaction with partners for better crisis and emergency management, to an immediate procurement of means, personnel, and equipment. Now, also the WHO wrote down an hospital emergency responsible checklist, so like guidelines for all the hospital. It means that all the hospitals that have a first aid point need to have a plan. Because hospitals play a critical role in providing communities with essential medical care during all types of disaster. Depending on their scope and nature, disasters can lead to a rapidly increasing service demand that can overwhelm the functional capacity and safety of hospitals and the healthcare system at large. Professor Antonelli just explained to you how rapidly the people needing the ICU treatment increasing, and we didn't have enough beds, ventilators, personnel to help them. So the World Health just developing this hospital emergency response checklist for emergency managers. What are the meaning, the keys? The 9 keys are structured with a list of priority to support hospital managers in achieving continuity of essential services, well-coordinated implementation of hospital operation at every level, clear and accurate internal and external communication, swift adaptation to increased demands, the effective use of scarce resources, and a safe environment of healthcare workers. And the key components are the same components that are for every kind of manager. If you think another type of work, it's always the same in the emergency: command and control, communication, safety and security, triage, the surge capacity, continuity of essential services, human resources, logistics and supply management, and post-disaster recovery. What is the final? So the Joint Commission points on 6 critical elements, which are communications, resources and assets, safety and security, staff responsibilities, utilities, clinical support activities. And the all-hazards approach allows ability to respond to a range of emergency, varying in scale, duration, and cost. It's not so easy and not so immediate for a hospital, because hospitals are used to work by themselves. I work with what I have, for what I do, with the personnel I have. But the COVID-19 experience teaches us that it's not enough. Within all health facilities, having a first aid point, the implementation of the EOPs is made mandatory in order to ensure that users presenting to the PS in an unscheduled manner for emergency problems receive timely, coordinated, uniform, adequate, and appropriate levels of care. But sometimes we have to face a very big emergency, and we have to measure how many people we can cure. So there are many different laws. I choose this one that is used in our hospital. It is taken from the military yes, from the Israel. And this formula says that you can take care a number of people measured with the name of the respiratories you have. Because if you have somebody very bad, maybe that person needs a surgery, needs an ICU, okay? And also, in Italy, but not also in Italy, in the most developed countries, there is the mechanism hub spoke, which means that you can have many hospitals, first level hospital, and then you have one hub, and one hub has some ultra specialties like neurosurgery, cardiosurgery, vascular surgery, that other spokes don't have. So maybe we call it in Italy 118, but the number is 911 or 112 in Europe. The emergency should know, reaching an injured person, where to send him or her to have the right treatment. This is an EOP operativity example. It has to be based on existing organization and structures. Be simple, understandable, necessary, be flexible, correctly sized. Must ensure that all personnel are aware of the procedures and tasks. Present reasonable compliance with the probability criteria, and be tested by the implementation of periodic exercises. This I don't repeat. I just want to underline this, that what happened in the COVID-19 emergency. At the first weeks, we didn't have prepared staff, and we didn't know how to wear it. Most of us didn't know how to wear. Lack of equipment for assisted ventilation, lack of dedicated pathways, insufficient or insufficiently pressurized oxygenation systems. In my hospital, there was an odd part. The oxygen wasn't enough to insufflate all the people recovered there. So we have to move all the people who needed oxygen to another part of the hospital. Insufficient beds, and inability to organize other types of emergency. But I want to say another thing. We didn't use predictive models. I just want to show these pictures because since the beginning, some scientists made predictive models, but probably we didn't listen to them enough because we could try to understand what would happen some days after, but we didn't. This already Professor said, so I don't want to repeat. I just was to tell you what happened on the territory. We had to convert hotels and they became COVID hotels. I mean, people who were positive and couldn't go back home, they went to live to the hotels. Hotels were closed because there weren't tourists. So hotels became COVID hotels. And also, the rehabilitation facilities, especially the one that we call the second level, the cardiorespiratory rehabilitation facilities, where people like COVID disease could cured, went there. And also, I want to underline also the volunteers who took the medicine at home to the patients, and the home visits of the territory doctors.
L'emergenza coronavirus che stiamo affrontando in questi mesi dimostra ancora una volta che l'emergenza sanitaria può avere importanti implicazioni anche dal punto di vista socio-economico e non soltanto a livello nazionale ma anche a livello globale. Pertanto bisogna mettere in campo strategie integrate per una prospettiva di miglioramento e per una società resiliente.
Before this pandemic, the bacteriological risk was inside the NBCR risk. People thought that it was a problem of the special corps, firemen, civil defense, but it demonstrates that it's not like that. Now, this is another letter that is N, that I think that we have to learn to face. So, at the end, what we can learn from this, that strategic and integrated planning is the only possible way to reach a safe development of the territory, the country, the continent. The emergency manager operates through the plans designed and implemented in interaction with each other in peacetime by appropriately trained professionals, prevention manager. And the prevention and emergency manager are interdisciplinary figures who operate in the complexity. The SARS-CoV-2 emergency has found us vulnerable because we hadn't created an European network of interdisciplinary professionalism. Thank you.